Hello and welcome back to the lecture series, Factors Influencing Ventilation, Perfusion, Gaseous Exchange and Transport. In part 2 of 4, we will concentrate on ventilation and perfusion relationships, i.e., as it's simple as it gets, getting blood and air in the same place at the same time. So in this section, we'll start off with further consideration of the conducting zone and the respiratory zone. On the perfusion side, we'll explore the characteristics of pulmonary circulation and finally getting down to the business of creating the causes for gaseous exchange. And just a reminder, in terms of the conducting and respiratory zones that we finished off the last lecture with, thinking about the function of the upper airway, the upper conducting zone, the function is to warm, humidify incoming air and to protect the structures of the airways. So cast your mind back for lecture 1 and the 3-coat scenario of the conducting zone. So in this case, we've used a bronchiole as an example. So just to refresh, we've got the outer coat, the protective coat of the airway, a middle smooth muscle layer, and a specialized epithelium. So hold on to that thought because at the next slide, we'll cover those areas in a little bit more detail. Okay, so this slide presents a little bit more detail from the previous slide. So we've got a larger airway again, a larger airway in the conducting zone, and you can see that's a cartilaginous ring present in this airway. So we've got the outer coat of connective tissue and the cartilage present in this cross-sectional view. We've got the smooth muscle, and embedded within that we've got a bronchial gland, and again the epi and endothelium providing the mucosa or mucosal layer of the inner surface of the airway. And you can see it's comprised of a range of cells, if I can highlight them there, in terms of ciliated cells. You can see the little hairs on top of the cells, and then the lumen above the sole layer, the mucous blanket, and mucus secreting cells interspersed within that row of cells. Okay, this structure, the mucosa, is of particular interest to us. It's really important in terms of defense. And again, you get this sort of sticky mucus layer which sort of traps dust, bits of bacteria, and so on. Okay, so mucus is produced continuously throughout the day, and within a normal adult or a healthy adult, it's around 100 mils of mucus per day. And again, it's a viscoelastic gel, as you will testify, really, if that's the right word, because again, it's the stuff that we cough and sneeze up or blow our nose, etc. So it's produced, and the cilia, pretty impressive stroke rate, 20 strokes per second in terms of wafting the mucus. So you get this so-called mucociliary escalator, moving mucus centrally so that we can cough up, sneeze, blow our nose, etc. For that. Okay, so stroke rate of 20 strokes a second, and again, probably not very impressive velocity really in terms of 2 centimeters a minute, but importantly, mucus irritation or mucus production increases with irritation. So, if you get an infection that irritates the airway, again, you'll probably be aware the number one risk factor in chronic lung disease is smoking. So a part of smoking, things like chronic bronchitis, which is characterized by excessive mucus production. Basically, smoke and the chemicals within the smoke irritate the airway, which result in a increased production of mucus. Take a short break after that, and we'll then consider our air moving through the airways to the respiratory zone and think about factors influencing gas volume in the lung. So this little bit will be revision from aspects of the first lecture. So we're back to dependent relationships of the movement continuum, and we're thinking about movement around the chest wall in terms of muscular activity, which I'm highlighting that point, acting on the joints of the thoracic cavity. So we've got to think about the costovertebral and costotransverse joints that we mentioned in the first lecture. And this movement is dependent upon the elastic properties of the thoracic cavity itself and the tissue working around that, and also the underlying lung tissue. We need to think about lung compliance, which is a type of elasticity, as you'll probably know, and also surface tension, the inner surfaces of the body being wet, to put it bluntly. So again, hold that thought. Thinking about factors influencing gas flow, and we really need to understand frictional resistance. Not something we usually think about because it seems to be a fairly low cost activity, breathing. It's about 4% metabolic cost at rest, but we need to understand frictional resistance in terms of the various layers of tissue moving over one another at the chest wall. Each layer, from the skin, subcutaneous tissue, muscle, fascia, the ribs, then to the pleura, and then lung tissue, they all need to glide and slide over each other to perform efficient movement. Anything that influences airway resistance and that will result in limitation of airflow, for example, inflammation or edema affecting the lumen of the airway, bronchospasm of the middle smooth muscle layer, sputum retention, excess production of sputum which doesn't clear, actually narrows the airway, or physical presence is in a tumor, or loss of tissue support. For example, a condition named emphysema, where you lose alveoli, or it's characterized by destruction of alveolar walls, or conditions which result in loss of lung volume, for example, pneumonia or pleural effusion. Muscular activity and the metabolic cost associated with this is termed work of breathing. For example, in relaxed breathing, very low cost work of breathing, as the diaphragm descends, increasing the diameter of the thoracic cavity and air flowing into the lungs. And I've mentioned about 4% of total metabolism in healthy subjects such as ourselves, but much higher in people with, for example, chronic lung disease. So just to recap then, in summary, respiratory muscle work or ventilatory muscle work needs to be sufficient to overcome airway resistance and tissue resistance, and this term is called work of breathing. You get bedside clinical indicators working with people through the respiratory rate. Okay, normal respiratory rate being around sort of 12 to 16 breaths per minute. The inspiratory-expiratory ratio, usually about 1 to 3 or 2 to 3. So, for example, on a 5-second cycle, 2 seconds inspiration, 3 seconds expiration. And again, the increased work of breathing comes at the metabolic cost, as we experience in terms of during exercise. And thinking about extremes of exercise and increase in respiratory rate, increased work of breathing, we can appreciate if that was the case where for most of our life, for most of the day, people with chronic lung disease, that's the scenario. Okay, so let's switch our attention to the perfusion side of things with a quick overview of the heart. So I can just highlight, we've said in lecture 1, the heart is a 4-chambered muscular pump, and basically consists of 2 pumps, so that you've got venous blood returning via the right atrium through the tricuspid valve to the right ventricle, and then ejected via the pulmonary valve through the pulmonary arteries, and this forms the blood supply to the lungs. Blood returns from the lungs via the pulmonary veins, which you can see marked PV on each side, and then enters the left atrium and via the mitral or bicuspid valve to the left ventricle and ejected via the aortic valve through the to gain this systemic circulation. For those of you who like flow diagrams, I'll leave this slide just for a few seconds for you kind of to follow the flow out, okay, in terms of the cardiac cycle and blood flow. On the next slide, we'll think about circulation and the vessels that make up the circulatory system. A very quick overview to give some sort of context into consideration of perfusion or blood supply to the lungs. Okay, this diagram gives a very simple schematic representation of circulatory vessels. So we've got a structure of an artery, which gives rise to smaller arterioles and then to capillaries and capillary beds, which join up to form venules and again in turn join up to form veins. Okay, we're back to really our 3-coat theory, really, similar to the airways. Obviously the epithelium or endothelium is a very different structure. It's specialized for function. So we've got a similar situation with arteries and veins. We've got an outer protective connective tissue layer, a middle muscular layer on each side, again, much thicker with in the case of arteries, and a very smooth endothelial layer, producing a kind of smooth lumen for blood flow in arteries. And again, you'll probably realize in terms of past study, in terms of the valves that are in veins to prevent backward flow of blood. Similar thing to airways. As we progress from artery to arterioles to capillaries, we gradually lose coats, so that at capillary level within tissue and within the lungs and the pulmonary circulation is particular interest to us now. We're thinking about the capillaries are 1 cell thick. And this slide even represents a signpost in terms of pathology, and a fairly gross one of that. So just in terms of summary, in terms of structure and function, in considering those two, for gas exchange you need air and blood in the same place at the same time. I think that's a fairly logical statement to make, but as simple as it gets, any pathology affecting the lungs, or pathophysiology of respiration, I've titled it there, you get a ventilation perfusion mismatch basically. So for efficient gaseous exchange, we need air and blood to be in the same place at the same time, but ventilation and perfusion must be matched for this to be the case. Okay, so failure to match, which we'll go on to consider over the following few slides, can cause a lot of abnormalities of oxygen and carbon dioxide exchange, and forms the basis of a lot of clinical features. So in summary, the story so far, okay, ventilation is defined by the gas movement between the outside of the body and the alveoli. Perfusion, we need to think about the dual circulation of the lungs. As I mentioned in lecture 1, there is a bronchial artery or bronchial artery system that supplies nutrients and removes waste from lung tissue, but also the pulmonary circulation, which is the circulation of interest to us at the moment. And it's the pulmonary circulation that's dominant within lung tissue. And as we mentioned in lecture 1, ventilation, and it is kind of dependent upon gravity and position. So the characteristics of which the airways and the alveoli even in the dependent regions are compressed by the weight of the lungs, but have greater potential to expand therefore. So if you can imagine the lungs hanging off the inside of the chest wall via the pleura, you'll get a certain amount of stretch on the upper regions of the lungs, the upper lobes, and again, this is characterized by them being inflated, but mainly dead space air. So stuff that's not really going to contribute too much to gas exchange. So the dependent areas from the top block there have more potential to ventilate and to expand. And in most spontaneously breathing adults, you and I, the dependent regions, the lower regions of the lungs, are generally better ventilated in an upright posture. So therefore, a gradient, a ventilation gradient exists favoring dependent areas of the lungs, the mid zones and the bases of the lungs. Similar picture to perfusion. For perfusion, as we discussed in lecture 1, the pulmonary circulation is a low pressure system, and therefore comes under the influence of gravity. So systemic circulation, I'm sure you're aware, the blood pressure within that system is on average in adults 120/80 millimeters of mercury, but within the pulmonary circulation it's around sort of 18 to 25 as a systolic pressure, and about 14 plus or minus 3 diastolic. So, for example, around about 24/15. So a much lower pressure system. So again, in terms of the pressure system, you get perfusion favoring dependent lung tissue. So the middle zones and lower lobes in an upright posture. So if you're sat up at the moment or stood, again, it will be the mid zones and lower lobes that will be better perfused. So we can say perfusion is affected by lung volume, because again, if you get extreme inflation of lungs, extreme ventilation will squish and squash capillaries, okay, and again, low lung volume again will apply a bit of a stretch. Position, as I've hinted, in terms of the lower lobes and mid zones favoring better perfusion in an upright posture, but also it can be influenced by pathological change. So joining up ideas in thinking about air and blood at the same place at the same time, or VQ as it's known, and you'll see that representation in the literature that you'll read around this. We get the following picture, that you've got APCs of the lungs, or upper lobes of the lungs, are of lower compliance at the bases because they're on a stretch. This is in the case of the upright posture. Okay. During normal tidal volume, relaxed breathing, there's greater volume distributed to the bases and the mid zones, and we've got to think about perfusion, the influence of gravity and pathology, which we'll mainly deal with next year, okay, but thinking about the influence of gravity and keeping an eye on the pathology. So again, in an upright posture, sitting upright, standing, we'll get more potential for ventilation and perfusion, and therefore gas exchange within the mid zones and the lower lobes of the lungs. Just a little quiz, something for you to while away the evening hours or part of the day. Bearing in mind what I've said in terms of the influence of gravity on perfusion and positioning on ventilation, what areas of lungs will be have a better VQ matching in the following positions: standing, sitting upright, sitting slumped, lying on your right side, or prone. So just something to think about in terms of those 5 positions. Okay, to summarize on the next slide, really, thinking about ventilation perfusion matching and mismatch, as simple as it gets. This is the usual picture, which is the arrow coming in here, represents pulmonary circulation. We've got an alveolus there, and we've got good ventilation of the alveoli, good perfusion, no problem. VQ matching, we've got a chance of gaseous exchange. Lung collapse, or as it's known, atelectasis, So we've not got any ventilation. It doesn't matter how good the circulation is, we won't get gaseous exchange. Similarly, an area of consolidation, for example, lobar pneumonia, again, it doesn't matter how good the perfusion is, we won't get gaseous exchange. And conversely, we've got good ventilation, but a pulmonary embolus, which blocks circulation or part of the circulation to the lungs, we've got wasted ventilation because we haven't got a perfusion to match this at all. Okay, so that brings us to the end of ventilation perfusion. Please take a little bit of a break and mull things over further. Okay, and I'll join you on part 3, where we'll get down to the business end of things and gaseous exchange. Thank you.